Good day, ladies and gentlemen. Hello, dear friends. My name is Vasyly Rohovyy. I'm the hand transplant patient and the founder of the Voice of VCA Patients from Innsbruck, Austria. Welcome to the interview. This time, our guests are Professor Emmanuel Morelon, head of the Department of Transplantation, Nephrology, and Clinical Immunology at Eduard Herriot, and Professor Aram Gazarian, head of the Hand Surgery Unit at Clinique du Parc, and chief coordinator of Specialized Emergency Network for Severe Hand Trauma. Professor Gazarian and Professor Morelon belong to the top global experts in the field of VCA. Good day, gentlemen. Glad to see you.
Thank you.
Good day,
Professor,
everybody.
good day, Professor Morelon. Professor Morelon, Professor Gazarian, my first question is to both of you. You were leaders and essential members of various multidisciplinary VCA attempts that performed the world's first bilateral hand transplantation at Eduard Herriot in January 2000 and the world's first face transplantation performed in November 2005 and also the world's first bilateral arms and shoulders transplantation performed in January 2021. May I ask you about your involvement in those programs and are you working on any VCA programs now? Please, Professor Morelon, could you please begin?
Hi, everybody. I just want to introduce myself. I'm a transplant nephrologist, and I trained at Necker Hospital in Paris for my residency and as assistant professor. And at this point of time, I specialize in transplant immunology to better understand the mechanism of graft rejection, not only for VCA, but organ rejection. And I joined the transplant team in Lyon in 2004. At this period of time, 2 patients had already been transplanted. It was 2 bilateral upper limb transplantation by the Max Dubernard team. So I became involved in the medical management of these 2 patients, as well as the next 5 additional patients who received upper limb transplant between 2007 and 2016. And I have also been involved in the follow-up care of the 3 face transplant patient that was transplanted in Amiens, because it's always a close collaboration between Lyon and Amiens for the face transplant patient, as well as the Icelandic patient who underwent bilateral arm transplant in 2021. And working closely with our multidisciplinary teams, we have been able to characterize both acute and chronic rejection in upper limb and face transplant recipient, as well as the complications associated with immunosuppressive therapy, which are very similar to what we observe in kidney transplant recipient. And at the present time, my research on immunosuppressive therapy, evaluating both their effectiveness, their side effects, and we are also working together to better understand the mechanism underlying acute and chronic rejection in VCA.
Thank you. Professor Gazarian, please.
Yes, thank you to give us the opportunity to speak and to present our experience and to share our experience in this field. I am now 67 years old. I am a hand surgeon and I trained in Lyon in this field and devoting my experience in both adult and child hand surgery. On this aspect, one of my dreams when I did accept to participate and to take the leadership of the surgical team of this experience in 2005, I had one idea behind my head, how we say in France, is to work on the feasibility to do this hand allograft surgery in newborns, to treat infants and child who have congenitally only one hand.
Mhm.
I was involved in this experience with Jean-Michel Dubernard in 2005. And as Emmanuel Morelon said, he was involved in 2004. So the first patient operated on in 98 and 2000 were operated without our presence.
Yes, I understand. Thank you. But you take part in the follow-up of Mr. Denis Chatelier, as I understand.
Sure.
Yeah.
I have two little corrections to add to your presentations.
Yeah, please.
The first is I'm not only working in Clinique du Parc Lyon, but now mainly in Hospice Civil de Lyon, which is the public hospital of Lyon, where I am head of the Department of Hand and Upper Limb Surgery. And the second thing is our experience with Felix Gretarsson, our upper limb amputee, as not to be described as a first mondial case. Before us, the Mexican team did the same operation, quite the same. And if there is something new in our procedure, is only technical details.
Yes, thank you for the correction. You mean Professor Iglesias, I mean. I
Yes,
think.
exactly,
Yeah.
exactly.
Yeah, okay. Yeah, Professor Morelon, one of your main research areas is long-term graft survival. As you know, 26, 27 years have already passed since the first unilateral hand transplantation in the US, the bilateral hand transplantations in France and Austria. You know all patients personally, Mr. Matthew Scott, Mr. Denis Chatelier, and Mr. Theodore Kels. I think it is a very remarkable fact that all of them have kept their hands till now, despite of being over 70. How do you think why? And could you also please add to your answer a little bit of transplant story of Mr. Denis Chatelier? My personal transplant journey has begun with an article about his surgery. How is it
Okay.
now?
Okay, so thank you for that very important question. The half-life of VCA, it's a very important question for us, but more for the patient. If you take solid organ transplantation, such as kidney or heart transplant, graft survival is about 15 to 20 years, depending on the graft. Sometimes it's much more, but sometimes it's less. For hand and for face transplantation, it is much more difficult to provide precise estimates because the number of transplant recipients worldwide remains relatively small. In our experience in Lyon, among the 7 patients who underwent bilateral upper limb transplant, 2 eventually lost their transplant graft. The first one lost the graft because of chronic rejection after 10 years of transplantation. He has a chronic vasculopathy, and so he lost the graft for that reason. The second patient in our series, that was the third patient transplant in our team, lost the graft because she asked us to remove the graft because she has a side effect of immunosuppression. And so she wanted to stop the treatment, so that for that reason, she asked us to remove the graft. But among the other one, all of them have their grafts, again, still here. And if you take Denis Chatelier, it is the first patient who received bilateral transplant. Now it's more than 26 years ago.
Yeah.
He has no evidence of chronic rejection. He has a fantastic function of his hand, even if it's not perfect. He's very happy with the hand. And he takes the treatment every day. And I think he takes it very well. And I will discuss later about chronic rejection and why do you have chronic or acute rejection. But the fact is, what is very important for me is that Denis Chatelier provides a proof of concept that an upper limb transplant can remain functional at least 26 years. And for me, it's a very important fact for patients.
Yeah, absolutely. Absolutely. Professor Gazarian, you were the leader of the team that performed the bilateral arms and shoulders transplantation to Mr. Felix Gretarsson, a patient from Iceland. Could you please explain to our viewers why his surgery was especially challenging from the surgical standpoint?
Sure, with pleasure. Let me tell the story as it is, and Emmanuel, please correct or add some data during my talk. When Felix came first, asking arms, we said we would like to do it, but we won't do it because the balance between the benefits you may have and the risk of this surgery is not good enough. There, he said, but look, you know, you are speaking about the risk and the risk of immunosuppression, but I have already an immunosuppression because I have a liver transplant. So here we began to think about the ratio and the balance in between the functional result and the graft process. And we are not very happy with the idea to make a very hard surgery, a long time surgery with a minimal result. Because, you know, the surgeons are quite egotic and they like have good results. And here it make us change our point of view, telling us, you know, I need not only function, I need also arms to be myself, to be complete. And he told us also, you see, my arms are very short and I am under immunosuppression. So even though the result would be very bad, I will ask you to cut my arms distal near the elbow, so I would have longer arms to fit better prosthesis than today. And with discussion, with reflection, we think it was acceptable to support his choice and go with him to the risk of this surgery. And we did it.
Understand. Yes, thank you. Professor Gazarian, in this context, how have the medical innovations influenced the way of planning and performing the hand transplantations and improved their outcome and post-transplant treatment? I mean, for example, would Mr. Felix Gretarsson surgery be possible in 1998?
Possible, I think, yes. Because technically, what we did this time could be done in 98. But the teams and the level of evolution of the concept was not ready to do something at this level of amputation.
Understood. Professor Morelon, you have just mentioned that you took part in the follow-up of the first face transplant patient, Madame Isabel. There are a lot of rumors around her story. Could you please clear them up? I think it is very important for other face transplant patient or potential candidates to understand the reasons behind her tragic ending. I understand it is very controversial question. I am asking you about this in the hopes that it will help other patients to avoid the same maybe mistakes, maybe issues.
Okay, no. Isabelle Dinoir lost her graft more than
Mhm.
10 years after the graft for chronic rejection mediated by antibodies. She develops a long time antibodies
Mhm.
against the graft. And after more than 10 years, she has a chronic rejection of the face. And then suddenly, in a few weeks, she lost the
Mhm.
face. The face was removed and she was reconstructed by conventional surgery.
Mhm.
And at this period of time, we wanted to give us a chance to have another face transplant. It was retransplantation of the face.
Mhm.
And so when we evaluate Isabelle for that, we discover that she has a small tumor in the lung. And this tumor is not due to immunosuppression because in any registry, you find this kind of tumors in transplant patients. This tumor is due to tobacco because she was a smoking person.
Mhm.
And so because of that, we couldn't retransplant this patient because of these tumors, and she died from these tumors. And we published that. So there was a publication that you can find in the scientific literature that
Mhm.
tells us that that's true. So she was not she has no disease. She didn't die from immunosuppression. She died from tumors not linked to immunosuppression.
Mhm. Yes,
So
thank you.
she has side effect of immunosuppression as many patients, but the side effect of immunosuppression was not responsible for death.
Yes, immunosuppression didn't cause.
No,
Okay.
not directly. No, no,
Mhm. Yeah,
no, no,
understand. Thank you.
no, no.
Professor Gazarian, could you tell our viewers, please, what kind of external organs haven't been still transplanted, and maybe you can also explain why?
I don't know if I can answer this question.
Mhm.
Uh, Perhaps ears have not been grafted, or nose, or I don't know. Penis have been done, and
Yes.
uterus also.
Mhm.
You know that the legs are not good indication for transplantation because fitting a good prosthesis gives better results than a leg transplantation. That's it. I may not be going further in this answer.
Mhm. But do you think legs transplantation would be possible to perform one day, so to say, in the future, or not?
Uh, the only way that a leg transplantation may give a good result would be the progress in the uh, neurologic result.
Mhm.
And there is perhaps some openings in those ways. No, there is one topic
Mhm.
where people are working on it. It's
Mhm.
the eye transplantation,
Yeah. Mhm.
which is which would be fantastic, but
Mhm.
very difficult to achieve.
Mhm.
And you already maybe you heard about the head transplantation, which has been to be called not a head transplantation but a body transplantation, which is also which is opening a lot of discussions.
Mhm. Yep. Thank you. Professor Morelon, I think you have heard that there are hand and face transplant patients who have never had any rejections episodes. How do you think why? What does it depend on? Maybe on matching process, donor options, time shortage for the transplantation, or what do you think about that?
About the patient has no rejection or
Yeah.
patient have a rejection. Okay.
Patients
Uh,
who have never had any rejections episodes.
okay. The first thing is every patient in the literature, in the registry, more than 85 patients have at least one episode of skin rejection
Hmm.
because skin is very immunogenic. And so when you transplant a skin, you expect to have rejection. And despite the immunosuppressive treatment,
Hmm.
85% have acute rejection of the skin, but you can treat the rejection. It's an episode, it's not a definitive rejection. So for me, it's quite normal to have rejection, to have an acute episode of rejection when you transplant a skin, and you have skin on the face and you have skin on the hand. That's why in our series of patients, face and hand, 100% of patients have at least one episode of acute rejection, 100%. But we treat this at the end, there is no sequela. The problem is chronic rejection. Chronic rejection is different than acute rejection. Chronic rejection is a result of the recipient's immune system gradually reacting over time against the transplant graft, and it develops years after years, not at the beginning of the graft. And in upper limb in face transplant, the chronic rejection and acute also rejection primarily affect skin and vessels. When it affects blood vessels, arteries, it causes them to narrow. In medicine, we call that stenosis. And the stenosis reduces the blood supply to the graft. And if this reduction of the blood flow is too severe, the graft is no longer adequately perfused, and ultimately this leads to graft loss. And this is what's happened to our patient who lost his graft for chronic vascular rejection. Our second patient in our list lost the graft after 10 years for that reason. He has a narrowing of these arteries due to chronic rejection. And when it happens, you have no treatment. So chronic rejection is not in all patients. It's patients have never chronic rejection, and some patients have chronic rejection.
Understand.
So chronic rejection is like a disease of the graft. And so you can say why patients have chronic rejection, why patients don't have chronic rejection. Usually patients have chronic rejection when they don't take the treatment adequately. They forget to take it, they decrease the dose. Sometimes they decrease the dose by ourselves. Sometimes we decrease the dose because of side effect. And when we use immunosuppression too far, if you decrease the dose too far, the risk is to have acute rejection over time. And that's what's happened probably to Isabelle Dinois. We have to reduce immunosuppression, and then she developed antibodies, and then chronic vascular rejection. And sometimes the patient takes the treatment at the dose we want, and despite that, he has acute and chronic rejection, because sometimes the treatment we offer to the patient does not adequately control rejection. And you don't know that before the graft. You know that after the graft.
Yeah,
and
understand.
This is for every transplant graft. Organ transplantation is the same, except that as VCA transplant contains skin, the probability to have acute and chronic rejection of the skin is higher than for organ, because the skin is more immunogenic.
Understand.
Okay.
Yeah, thank you.
And Denis Châtelet, for instance, has no evidence of chronic rejection 26 years after the graft, probably because he takes the treatment adequately, but maybe also because he don't have a strong reaction against his graft.
Yeah, understand. So to say, it depends also on patients.
Yes, it depends on treatment, on patients, and on other factors, immunological factors, very complicated to explain in this interview.
Okay. Yeah, understand. Professor Gazarian, I think you have heard about French patients who underwent the hand transplantation abroad. And there are also foreign patients who underwent the hand transplantation in France. How do you think, do we need an international follow-up or European follow-up system for face and hand transplant patient? I mean, for example, we patients have never thought about that the hand transplant program is closed, or our doctors will retain, and there is no adequate treatment in this case. Therefore, I'm asking you about the European or international follow-up system. Is this question discussed on your meetings, transplant meetings, with your colleagues from other countries?
As far as I understand, there is many questions in your question. And you know, the reason why a patient from outside another country want to have a graft in France may be the consequence of impossibility for him to be treated in his own country.
Yeah.
And on the contrary, the reason why a French patient may be operated on elsewhere, for instance, the case in US,
Yeah.
are for different reasons, which are somewhere political and social. The fact that in between the teams, work needs to be done to better understand on a community level, international level, the different steps of this care is important, sure. It is the reason of our international congress and the societies which are involved in the hand allograft, as you know.
Okay. Professor Morelon, one of your main research areas is also renal function, so to say, side effects of immunosuppression therapy on kidney. May you explain, please, why are the renal function of immunosuppression therapy one of the most adverse effects after the hand and face transplantation?
Yeah, that's thank you, Vasyly. It's a very good question. You know, I'm a nephrologist. So
yeah.
This question is very interesting for me. You know, the immunosuppressive therapy used after transplantation to prevent rejection is a combination of 3 drugs: tacrolimus, mycophenolate mofetil, and steroids. And among these medications, tacrolimus can be toxic for the kidney.
Yeah.
And we know that because we give tacrolimus kidney transplant patient, and in every organ transplant patient, and we know that tacrolimus is maybe, especially when the dose is high, is toxic for the kidney. And so we expect that.
Yeah.
The fact is, what an important point is that in VCA, usually the patient have a normal renal function before the graft because they have no disease. They have been amputated or disfigured, but usually they have no disease. So they start with a normal renal function. And so the toxicity is not so high. So in most cases, we just published it very recently. The impairment of kidney function is mild to moderate. It's not very severe, but in 1 or 2 cases in the world, patients require dialysis. So there is an impact. Usually it's mild, but it could be more severe.
So to say, there are treatment options for the patients who have this this issue with kidneys besides kidney transplantation. Yeah.
So when this happens, it's very difficult because the best solution would be to stop tacrolimus because this is a toxic drug. But if you stop tacrolimus, the risk of rejection is very high because tacrolimus is the most powerful drugs against rejection. So we want to avoid to stop tacrolimus. So what we do, we decrease the dose of tacrolimus to reduce toxicity, and we try to add 2 different drugs. One is everolimus, and one is belatacept. And for the present time, there are only few cases describing that what you want belatacept maybe you reduce the toxicity, but I think this is the best approach. But it's probably dangerous to totally stop tacrolimus by replacing to belatacept because belatacept is less efficient against rejection than tacrolimus. So I think what we have to do, if we observe that now, you have to monitor the graft function from the beginning very precisely. This is just so you have to monitor serum creatinine in the patient.
Yeah.
And if you have the diminution of renal function, you need to discuss with your team. Do we have to decrease the dose of tacrolimus by adding another drugs? If you do that like that from the beginning, probably you avoid the deterioration, severe deterioration of renal function. And that's what we do in our team now. In our team, every patient keeps its kidney with a good function. There is a reduction of renal function, but not severe.
Yeah, thank you. This is a very important question. Professor Morelon, in this context, as you know, ESOTA, European Society for Organ Transplantation, together with European transplant organ patient organizations, Allian, organized a few workshops about ECP treatment, extracorporeal photopheresis. As far as I know, your hospital is one of the few who implemented this type of treatment for your patients with solid organ transplantation. Would it be possible to apply this experience to the treatment of the patients with external organ transplantation?
Yeah, thank you. This is quite a complex question.
Mhm.
It's difficult to explain how does it work, but I will try to do it. Okay. So that workshop focus on the concept of immunomodulation more than immunosuppression. Okay, let me try to explain that. The principle of all transplantation is to administer immunosuppressive treatment that block the immune system and to avoid rejection.
Yeah.
When you do that with a classical immunosuppressive treatment, you decrease the patient immune defenses. And so you make them more susceptible to infection and to certain virus-related cancers.
Yeah.
So this situation is very difficult when a patient develops acute or acute rejection because you need to increase immunosuppression. But if in the same time he has an infection where you should decrease immunosuppression, the situation is very complex because in one side you have to increase for rejection, in the other side you have to decrease. So to manage that, one possibility is to use extracorporeal photopheresis. That's what you mentioned. This treatment is not immunosuppression, it's immunomodulation. That means that it modulates the immune system, but there is no immunosuppression, so it did not reduce the defense of the patient. And so this treatment is used in organ transplantation, cardiac transplantation mostly, also in GVHD disease, in hematopoietic stem cells transplantation, and in some case of kidney transplantation. And so because of that, we treat some patients in our cohort. We treat 2 transplant patients and 2 phase transplant patients that had rejection plus an infection with these drugs, with these techniques.
Yeah.
So we already did it for external, for what you call external organs that are VCA.
Yeah.
Does it work or not? It's very difficult to say because there is no randomized study, so you cannot compare this treatment to no treatment in a control group. So for an individual, you don't know, maybe there is an effect because for our patient, we think that there is a reduction of rejection and not no more infection. But it's not scientifically proven. It's just an impression. And randomized study so far does not exist. So I think it's still experimental, but it's an option. It's an option.
Yeah.
The problem is it is technically demanding and not widely available. So it's not so easy to do, but if we have to do, you can try.
Yeah, thank you. Yeah, this is a very important information. Professor Gazarian, you belong to the notable French Armenian personalities. Excuse me if I'm flattering you, but as Monsieur Alain Prost, Monsieur Charles Navour, as far as I know, you have visited this country, Armenia, I mean, for a few times to help your colleagues there. It would be very interesting to know, is there any interest to the external organ transplantation in this country?
Thank you for your introduction about the country and the nation I am belonging to. I am French, but I feel Armenian. So the level of transplantation in Armenia is low. Is low, and you can say there is transplantation, only kidney transplantation, and from donors, from alive donors. There is no organization of organ how we say, donation in Armenia right now.
Yeah. But how do you think, is there any interest for the external organ transplantation? I mean, maybe you try to develop some programs in Armenia with your colleagues.
During the different wars which happened in Armenia, there is a lot of soldiers and people who lost their limbs, and rarely, but sometimes bilaterally. So we had the opportunity to see a few patients like this who were asking for transplantation even in Armenia. But no, it's not. It is not the time to think about this in Armenia, because this care is not only surgery. This care is medical and rehabilitative, and histology and psychology, and so much things have to be concentrated around the patient to make the success. So it's not the time to think about it in Armenia.
Yeah, understand. Professor Morelon, Professor Gazarian, my next question is to both of you. You are active members and participants of renowned reconstructive transplantation and plastic surgery societies and meetings. I think it would be interesting for our viewers to know what are the most promising or most often discussed topics on their agenda.
You know, there are two societies involved in VCA, dedicated to VCA. An American called American Society of Reconstructive Transplantation, and the International Society for Vascularized Composite Allotransplantation. We participate to both, but mostly to the international. We have one meeting every 2 years. So the last meeting was held in Helsinki. You were there. I think you were there. Yes, we met there. And the next one is in Seoul, South Korea, in 2027, I guess.
In Taiwan.
In Taiwan, sorry, in Taiwan, yes. And so in this meeting, we discuss all the aspects of VCA, because we are all specialized in VCA. And this, for me, it's the best meeting for VCA, because all these physicians, surgeon, immunologists, biologists work on VCA with VCA patients. So for me, it's the best place to discuss. In other society like ISOT or ATC, there are some section on VCA, but not so much, because the surgeon, the on-transplant surgeon, they are not organ transplant surgeon. And the face transplant surgeon, they are not organ transplant surgeon. So they don't participate to organ transplant societies. And so there is, in these societies, there are only few sections. And so what we, that are important, but so I think we have to focus on the two specialized societies. But Aram will give you the answer for the hand surgery. For plastic surgery and maxillofacial surgery, usually they're organized symposia. For instance, in Athens, in September, there is a special sympo on face transplantation organized by the maxillofacial surgery. And I will be there.
Yeah, fine.
Aram, do you have many discussion on transplantation in your hand surgery societies?
Not so much.
Not so much.
Not so much. It seems that during inside the societies, there is a part devoted to hand transplant, but it's something apart. It's not very followed by the majority of hand surgeons. They consider that it's a special hyper specialization. Yes.
They don't do it. They don't practice.
Yeah, understand.
Because in each country in Europe, in each country there is only one or two centers, and usually in a university hospital. So it's still a small world.
Yes, and we understand why it is small, because facing the hand allograft is very demanding, as much for the patient than for the team which are taking care of it. And the progress and the challenge you were speaking about are both technical, how to do better the surgery to succeed it, not only on the surgical aspect, but medical also. And the second aspect of the challenge is what have to be the relationship in between the patient and the team we are taking care. In order, the expectation and the expectations of the patient are well understood and well answered.
Yes, understand. So to say, the patient should be, as a member of the team.
Sure.
Yeah, okay. Professor Gazarian, Professor Morelon, my last question is also to both of you. You belong to the brilliant constellation of French surgeons, nephrologists, transplantologists. It would be interesting to understand what will happen to the field of VCA in France if you and your colleagues, such as Professor Laurent Lantieri, Professor Palmira Petruzzi, Professor Alexandre Lelouch, step away from praxis. Is there a new generation of surgeons that will carry on your work?
I think we cannot speak on for Laurent Lantieri because I don't know what Laurent Lantieri wants to do when he retires. But in Lyon, Aram and me, we are not alone in our team. We have a team and they work with us for years and years. And so it's not that we were alone. We are not alone. We teach, we discuss with them, and so they are ready to replace us.
Yeah.
And they start to do it. For instance, Christophe Gaillard, Aram will talk better than me, is going to replace Aram as a leader. And in my team, Xavier Charmeton, it's a transplant nephrologist, is going to replace me. And so don't worry, we are not going to leave the patient alone. And what we want to do is we don't want to stop the program. We want to go on with the program.
Our patients already knows Xavier Charmeton on the medical aspect and Christophe Gaillard on the surgical one, and perhaps Robin Fauconnet, which is on my side, and quite young, quite still young. Yes, they are ready for. They will do better than us, I hope, and with the willingness to do it, so they are going to be ready.
Excellent, excellent. Yes, Professor Gazarian, Professor Morelon, thank you very much for your participation in our patient initiative Raise Awareness about VCA. Thank you very much for your time. That was very open and a very open and interesting discussion. I hope our viewers will like to listen to us. Yes, I wish you and your patient all the best, and of course, strength in the hands.
Thank you, Vasyly, what you do for patients.
Thank you very much.
Yeah, wish you a nice evening and many thanks for your time. And I wish you both all the best.
Bye-bye, everybody.
Thank you, Vasyly.
Bye-bye, Vasyly. Thank you. Bye-bye.
Have a nice evening. Yeah, goodbye.
Bye.